Welcome to the Radiology Review Podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Welcome to the Radiology Review Podcast. The last episode covered anterior mediastinal masses, and this episode will cover questions and answers pertaining to middle and posterior mediastinal masses. A free downloadable study guide on this topic is available at theradiologyreview.com, so check that out if you are interested. I also want to let listeners know that I recently posted the Radiology Review Guide to finding your perfect job, so go ahead and check that out. Without further ado, let's get into the questions and answers for this episode. First question: what are the most common middle mediastinal masses? The most common middle mediastinal masses consist of enlarged lymph nodes, foregut duplication cysts, and aortic arch anomalies. Lymphadenopathy should be the first thing to consider for middle mediastinal masses, but you must exclude other processes as well. Next question: what are two fat-containing masses that can present in the middle mediastinum? The answer I am looking for is lipoma and esophageal fibrovascular polyp, as these are fat-containing masses that can present in the middle mediastinum. Next, what are some vascular processes that can present as middle mediastinal masses? The answer I am looking for is that aortic arch anomalies, such as an aortic arch duplication, as well as an interrupted inferior vena cava causing azygous continuation, can both present as middle mediastinal masses. Next, what are some subtypes of foregut duplication cysts? Mediastinal foregut duplication cysts were confusing to me as a resident. Here are some keys to keep in mind. First of all, foregut duplication cysts are most often bronchogenic in etiology, lined with respiratory epithelium, and those have a propensity for infection, which you should suspect on radiology board exams if an air fluid level is seen. Bronchogenic cysts most commonly do not communicate with the bronchial tree, and therefore are not commonly air-filled. Again, if you see an air fluid level within a cyst, you need to be concerned about the possibility of an infected bronchogenic cyst, which can be a manifestation as well that communication with the bronchial tree has now formed as a sequelae of infection. On imaging, look for a rounded fluid or soft tissue density mass that can cause compression of adjacent structures. And if the airways are compressed, this can be a cause of a hyperlucent hemithorax. Sometimes you can see layering milk of calcium within the bronchogenic cyst. Additionally, mediastinal foregut duplication cysts can also be of esophageal origin, and these may have a propensity to bleed due to presence of ectopic gastric mucosa, and these normally have pseudostratified columnar epithelium. Esophageal foregut duplication cysts are more common on the right aspect of the mediastinum. These can cause symptoms of dysphagia due to external esophageal compression. Note that neurenteric cysts, that is Neurenteric, neurenteric cysts, also exist in the posterior mediastinum and are rare but have a hallmark of communication with the spinal canal and an associated vertebral body anomaly. Next, what are common differential considerations for posterior mediastinal masses? Most posterior mediastinal masses have a neurogenic etiology to include neuroblastomas, schwannomas, and neurofibromas. Other considerations include extramedullary hematopoiesis in the setting of various causes of anemia, lymphadenopathy, neurenteric cysts, as already discussed, meningocele descending aortic anomalies such as an aneurysm, and bone processes related to the vertebrae to include discitis osteomyelitis with possible paravertebral abscess, Ewing sarcoma, chondrosarcoma, and so forth. A more extensive list of posterior mediastinal masses that are neurogenic tumors include neurofibromas, malignant peripheral nerve sheath tumors, schwannomas, paragangliomas, pheochromocytomas, chemodectomas, neuroblastomas, ganglioneuroblastomas, and ganglioneuromas. You don't need to necessarily memorize all of these, but I point this out to drive home the association between posterior mediastinal masses and neurogenic tumors. Lastly, don't forget about hernias, to include hiatal hernias and Bachdelic hernias that can present, although not exclusively, as a posterior mediastinal mass. Next question. What is the cervicothoracic sign? To keep it simple, if you have a mass that arises above the level of the clavicles and there is lung tissue anterior to the mass, then the location is in the posterior mediastinum. Note that the anterior mediastinum does not arise above the level of the clavicles. The cervicothoracic sign, again, is if you have a mass that arises above the level of the clavicles and there is lung tissue anterior to the mass, then the location of the mass is within the posterior mediastinum. Next, what are causes of anemia that can be associated with extramedullary hematopoiesis? Causes of anemia that can be associated with extramedullary hematopoiesis can include leukemia and lymphoma, myelofibrosis, polycythemia vera, sickle cell disease, hereditary spherocytosis, and thalassemia. Next, true or false? Extramedullary hematopoiesis can present as a fat-containing mass. The answer here is true. Fat can be seen within sites of extramedullary hematopoiesis, especially if long-standing. Next, what must one consider prior to biopsy of a mass that may be related to extramedullary hematopoiesis? Sites of extramedullary hematopoiesis may bleed as a result of biopsy. On a board exam question, be cautious before recommending biopsy of a site of extramedullary hematopoiesis, and if tissue sampling must be performed, fine needle aspiration may be a better option compared to core needle biopsy. Next, besides the posterior mediastinum, what other locations can have involvement of extramedullary hematopoiesis? Extramedullary hematopoiesis can also commonly affect the liver and spleen, and less commonly affect other tissues to include the adrenal glands, lungs, breasts, GI tract, skin, kidneys, brain, and so forth. Perirenal soft tissue masses that can look similar to renal lymphoma can occur with extramedullary hematopoiesis and is one way this entity can be tested on board exams. Also note that bony expansion, such as rib expansion, can occur. Next, what are differential considerations for masses that don't respect assigned mediastinal boundaries? Note that mediastinal boundaries are arbitrary, and there are no actual soft tissue structures or tissue planes that isolate tissues to one compartment versus another. However, when you see a mediastinal process that crosses or encompasses multiple mediastinal compartments, consider infections such as mediastinitis, malignancy to include a primary lung malignancy, liposarcoma, and metastatic disease, as well as mediastinal hematomas and lymphangiomas in the differential diagnosis. Next question. What is a testable link between pancreatitis and middle mediastinal masses? Occasionally, pancreatitis can cause a mediastinal fluid collection, an intrathoracic pancreatic pseudocyst, that can present as a mediastinal mass. So if you are presented with findings on imaging or laboratory values suggesting pancreatitis and they show you a mediastinal fluid collection, a differential consideration is an intrathoracic pancreatic pseudocyst. Last and final question for this episode. What is Castleman disease? Castleman disease is a commonly tested concept and fits within the differential of mediastinal masses, so let's go ahead and talk about this here. Castleman disease is angiofollicular lymph node hyperplasia, which is essentially a benign type of B-cell lymphoproliferation that causes a solitary or multicentric hypervascular lymphoid hyperplasia, with unicentric involvement being most common. If unicentric, classic presentation would be a younger patient presenting with a thoracic mass, although this can less commonly be seen also in the neck or abdomen or pelvis. If multicentric, think an older population of patients with coexisting HIV and human herpes virus 8, which is HHV8. Treatment for unicentric Castleman disease is often surgical, and multicentric disease may necessitate surgery, chemotherapy, steroids, and possibly antivirals because of that coexisting HIV and HHV8 association. Note also that there is an association between Castleman disease and POEMS syndrome, POEMS syndrome. I would also be aware that multicentric Castleman disease often has additional symptoms that overlap with lymphoma, to include fevers, night sweats, weight loss, and hepatosplenomegaly. Diagnosis of Castleman disease is made by lymph node excision or biopsy following exclusion of other causes of lymphadenopathy. Thank you for listening to this episode. If helpful for you, free study guides on the topic of mediastinal masses are available at theradiologyreview.com. Also, I want to put in a plug to contribute to the Radiology Review Journal. If you have a story to share that is pertinent to medical imaging in the United States or abroad, I welcome your submissions that can be sent to contact@theradiologyreview.com. Keep up the good work and study hard. You have to study really hard to succeed on radiology board exams. So prepare to succeed. I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.